I'm going to be presenting a research project that I worked on. It was an NIH R01 grant, and we sought to obtain the clinicians' perspectives on EHI design features that would impact the physician's perception about how AI is valuable or if it is valuable. So I added the "Are we ready for real-time AI-based decision-making" for you to really think about as we go through this presentation. So it was an NIH R01 grant. The title of the grant was Timely Response to In-Hospital Deterioration through Design of Actionable Augmented Intelligence. The person who really conceptualized the grant was an interface designer. So she really wanted to focus on interface design. Melanie Wright was her name. She was in Boise, Idaho, working for St. Alphonsus for some time, and then joined Idaho State University for a short time. And then she moved on to some government agency in Washington, D.C. So it would have been a conflict of interest for her to continue to work on the grant. So she left it with us. Those were the 4 aims. I'm going to talk about the second aim, which is what I was asked to join the group with and help with, which was the second aim was to understand the clinicians' perspectives on how the clinical context, and human AI design features impacted the usefulness of AI. So we do have a publication out of this, came out last year in JAMIA. There's a lot more detail in this publication than I will go into on this slide, so you can refer to the publication for more details. So for the aim 2 objectives and tasks, we really, as I said, we wanted to understand clinicians' perspectives on the clinical context and what was happening with the patient and how providing them with augmented intelligence design features, how they felt that was useful to them or if it was useful to them. So at the first part of this aim, they created patient cases, and they based those on a temporal reasoning model that they did in aim 1. They created a temporal reasoning model. They applied that to University of Chicago data, actually, and they applied a risk prediction ECART algorithm. And if you're a clinician, you probably know what that is. It's an early warning score to kind of identify deterioration of patients within the next 24 hours. And that served as the context for evaluating the cases. Served as a context for evaluating the clinician's perspectives. And the early warning score was embedded within a simulated EHR that we used. And then we qualitatively captured the clinician's perspectives during case review through interviews embedded in the case review. And I'll talk a little bit more about that. The cases, they were cases with diagnosis. They were non-critical care cases. Cases with diagnosis of sepsis, acute kidney injury, or both. The prediction model that was used was ECART based, and it's just an early warning score for deterioration. When they did the temporal model, they ran it against the data, then they selected the cases that had an ECART score, where some scores were below 20, which is the danger zone, up through above 97. So anything that got flagged less than 20 with the ECART score, the patient would likely deteriorate significantly within the next 24 hours. So they selected a variety of cases. Cases were really synthesized based upon temporal relationships between that score and the vital signs in the lab data. There was a mix of true positive, false positive, and false negative cases across the diagnosis, and then there was a couple control cases. So for the case analysis, we had a simulated EMR system. University of Pittsburgh created a simulated EMR system that can be used for research purposes. So they worked with the group from Pitt to get all our data in there and set everything up. And it provided a case list, and I'll show bigger screenshots of these the screens for the analysis system. But it had a list of cases and a brief summary. And then it had, when you clicked on a case, it gave you some details for that patient, and it provided demographic and clinical data provider H&P admission notes plus progress notes for the first 24 hours. And most of the cases also had progress notes for the next 24 hours. So a total of 48 hours after hospitalization. It had some hover over features, so it was interactive. You could hover over these dots and it would display the numerical values. You could click on the dots and it would graphically display all the other graphs at that point in time where you clicked on it, what those values were. So there was some interactivity in it. There's a slider bar up here that you could use to adjust the data in and out. We told them where to put the slider during the interviews, and they weren't able to do what they probably normally would do, which is zoom in and out during their regular analysis. So we kind of restricted them a little bit. This component that we dropped into this simulated EMR is not a true AI component that is sitting there reading data and changing, dynamically real time. That's what it's supposed to simulate, but we didn't have the real time feature built into the system. So when I was interviewing some people at the end, they said, well, you're not really doing AI. You don't really have a component there that's reading. And that's very true, but we were in a simulated environment. So before they started the case analysis, I demoed the system for them, showed them the features, showed them where the early warning score was. And so they could understand the system before they started. So this was the case selection. I told them what case to select, and they were given the age and the admitting diagnosis. This is the actual patient screen that they had access to. This is a scroll bar, so there were more graphics here. Up here in the top is demographics. This is the slider bar that they could adjust. They categorized the clinical data into like these 4 categories. They had H&P data. This case only has progress notes for 24 hours. Most of them had an additional one, and these are tabs that they could click on and scroll down through there. This is the early warning score, the deterioration risk here. And if you clicked on any one of these, vertical lines would show up. So you could see the corresponding data. Yes.
What's the vertical axis?
Oh, time. This is time across here, and this is the score itself. So it's a score over time.
And then the color coding is?
The green is it's in normal range. The orange is you're getting outside of normal range, and the red is that you're in the danger zone.
Okay, I guess. Okay, and those are different. I was trying to correlate the reds with vertical position, and like some of them, the reds are low and some of the reds are high, but it's different variables.
Right. It depends on that clinical data.
Got it.
So yeah, the vertical axis is the score and the horizontal axis is the time. Okay. All right, so the contextual interviews, the objective was to really identify factors that influenced their perception of usefulness of AI. We were looking for general factors that are pretty common across patient populations and specific factors related to specific contexts. If it was a complex case, if that patient had a lot of chronic conditions, if they were in a dire state versus a non-critical state, what kind of specific contexts would adjust their perception of the value of AI? And then what general factors could they apply across patients regardless? The subjects were physicians, nurses, and rapid response team personnel. We had mostly MDs. We did have a DO. We had nurses, and then the rapid response. We recruited across the U.S., so we had subjects from all over, from academic healthcare settings as well as non-academic healthcare settings. We had several from the VA that we participated. There were 12 participants, 4 in each group. People that were associated with the research or people who are on the advisory panel referred people to us to contact for participants. So that's how we got the participants. They were compensated for their time, $150 for most of the interviews were 90 minutes. Some were less than that. The specifics of the demographics and the race and the gender and all that are in the paper if you're interested in the breakdown. Okay, so the case analysis and the interview process. I started by asking baseline questions about the general knowledge of AI and how they feel about AI and risk prediction. And I'll show you the questions here in a minute. Then they were told to look at the H&P data, the admission data. They had a few minutes to look at that. Once they were ready, I asked them some additional questions, and I'll show you the breakdown of the categories of the questions. Then they were given the first day progress notes. They could review that. They were asked additional questions and progress notes too, if there was a second progress note. And then at the end, I asked them information about their trust of AI. And yeah.
How many groups were there?
There were three groups, I'm sorry, three groups, 4 in each one. Okay, so we created an interview guide that is available in the supplementary material if you're interested in seeing that. The sessions were conducted over Zoom. They were instructed on how to access the EMR. So I gave them the link to access it. I gave them the demo. They shared their screen so I could see what they were doing. And everything was audio and video recorded. They could turn off their camera if they didn't want to be on the video. We only analyzed the audio recording data though, because that's what was written in the IRB protocol. But we did have access to view what they were doing on the screen as well. But that was not, we didn't have that in the IRB protocol, so we couldn't really factor that in. As the person who did all the interviews, it was hard to separate that out when I did the analysis, but we did the best we could to separate that out. Okay, so the interview questions were baseline knowledge. What do you know about risk scores, predictive modeling? What's your general feeling about AI in general? We really wanted to capture their clinical reasoning and their cognitive processes and their mental models. We really wanted to understand what they knew and how they perceived AI and the usefulness of it, and then their trust of AI. So, and we can't advance my slide. Okay, there we go. I'm not going to go through each one of these questions, but the baseline knowledge questions were, just tell me about your feelings about AI. Have you used risk prediction scores and prediction modeling scores before? What do you think about them? For cognitive reasoning and processes, we ask them about what information stood out to them, what information helped them to know whether the patient was going to get better or worse. Are they looking for specific patterns? Is there certain data that they were looking for, and what actions would they take? Understanding AI, we asked them to talk about the usefulness of the early warning score. What was it telling them? Was it useful to them? Why was it not useful? If it wasn't useful, would there be a different interface approach that would make it more useful for them? What actions would they take on the early warning score? And how would they like to receive AI information embedded into the EHR? Questions at the end regarding trust was, tell me more about your thoughts and feelings about the EWS score and AI information in general. Do you feel that what is presented is accurate? Why or why not do you trust it? If you don't trust it, why don't you trust it? If you do trust it, why do you trust it? What information should be given for you to trust it even more? And we asked them about what they knew about the limitations of AI, just to see what their knowledge base was. So for the analysis, it was a qualitative analysis aim. So like I said, we audio and video recorded the analysis. We transcribed the audios. We did qualitative methodology, thematic analysis, and content analysis, which involves open coding and then axial coding to collapse like codes. We generated a code book, and then we looked at the codes to determine what themes were emerging. The coding process was a team of 3 people, myself as the informaticist, a PharmD, and an MD. He was a BMI trainee at the University of Utah. He had gotten his MD overseas and came over and was in the BMI program. So he wasn't a practicing physician, but he did have the base knowledge. We coded together, we sat on Zoom and coded together 3 transcripts and worked through 3 transcripts together. So we collaboratively coded. I created a code book, and to make sure that everybody was familiarized with the code book and doing the same thing with it, each one of us independently coded the same transcript. Then we brought the codes back together and looked to see how each other coded to see if we needed to make any adjustments. Then I split the remainder of the transcripts up and assigned coder pairs. And every coder pair had a clinician. It was either the pharmacist and myself or the MD and myself. And we had 2 people code each transcript. After we got done 2 or 3 transcripts, we would all come back together again. I would merge the codes and we would all come back together again to see if we were coding similarly and make adjustments if we needed. So we were very integrated throughout the process and came back and looked at what was happening. We purposely integrated a clinician in every single coding of every single transcript to bring in the clinical expertise. Okay, the results were presented in a couple different ways in the paper. The senior author was not a qualitative person. He insisted that we do non-qualitative analysis and report non-qualitative analysis. So we broke it up into these 4 domains of familiarity with and understanding risk scores, prediction models, and AI, clinical reasoning processes, impression and response to the EWS, and interface design. So in terms of understanding their baseline knowledge, the clinicians that participated generally had a familiarity with risk scores. A lot of them commented that they have deterioration indexes and sepsis indicators in their EHRs. So they were pretty familiar with them. They had had some exposure to them. The knowledge on prediction models and AI and how it worked, it really varied. A lot of them very confidently said they knew how it worked and they described how it worked, but what they were describing was not really how prediction modeling works. So it varied there. For clinical reasoning, the clinical data focus, they started reviewing the cases and they really focused either on the provider notes and or the clinical data. Never even looked at the early warning score. Never ever looked at it on the first case at all. To determine the patient's trajectory, they really relied on the vital signs and the lab data, which is what they do in normal practice. They didn't look at the EWS to early warning score to determine that whether the patient was declining or not. We asked them about what actions they would take. The actions that they took were based on, again, the clinical data and their own gestalt, and not on the early warning scores. So then we asked them their impression and response to the EWS after the first couple segments of reviewing data. We specifically asked them, does the EWS make sense to you? What is it telling you? So once they were forced to look at it, they did not look at it at all initially, but once they were forced to look at it, they began to consider it and integrate it a little bit more. So they didn't look at it at all at first. Once they were prompted to do it, they started looking at it. They felt like they had a general idea, again, of risk prediction scores and what the EWS was saying. But again, their actions were not based upon that at all. It was based upon their own clinical gestalt. They really said a lot about not knowing the underlying algorithm and what it was based on and how the prediction model was validated. That was really important to them as well, some more than others. So the interface design, they did want the early warning score in a dashboard type display so they could use it to really triage, essentially, to pick which patients needed to be looked at first. They did want it in the individual patient display, and they did want it embedded in the clinical data so that they could look at the clinical data and the early warning scores together to kind of get some context. They did also want links provided where pop-ups would pop up to explain the algorithm, what variables it was using, what weights were assigned for each variable, how the model was validated. They didn't want that on the screen all the time to take up real estate, but they did want it available to them. And then the ability to customize the screen. That wasn't really anything new for this study. They usually have the ability to do that with EHRs anyway. So the qualitative side of things, which was what my role was, we really came up with 3 predominant themes. Trust but verify was huge. The most predominant theme there was. In EWS, usefulness and clinical actions, and those 2 components kind of step on the part or similar to what I just said. And I kept saying to my senior author, this is taken away from the qualitative part of the paper. And he's like, I need it in there. I want it in there. I'm okay. You're the senior author. You're a seasoned researcher. You got it. So we included both. But those 2 components you'll see kind of are the same as what I've talked about. But there was a definitely trust but verify. They were willing to trust it, but they wanted validation about it. And their trust was really based upon their understanding of the model and what was underneath in that black box and their experience using it. So there was limited trust because of score unavailability and lack of knowledge. They felt that that could be rectified if they understood the algorithm more, and over time and using it, they would get more comfortable with it. It was also based upon whether the model could discriminate or not about whether the EWS was high and in the danger zone for a really valid reason. There was a lot of those cases where the patients had chronic conditions, and it was explainable that the EWS was high. So they wanted some intelligence built in to kind of weed out the noise, and only show me cases where that's high when there's not really an explainable reason for it. And then this was interesting because they trusted it as long as it aligned with their clinical gestalt and what they were thinking, but they didn't trust it if it didn't. It's kind of like confirmation bias. Confirmation bias was a thing that I studied in my master's thesis when I was analyzing physicians' use of cognitive heuristics and biases. They go looking for things to affirm what they already believe and refute things that go against what they believe. So there are participant quotes for all of these things in the paper. I didn't take time to put them here, but some of the quotes are really interesting to look at. The second thing was the usefulness of EWS. There was a real dichotomy here. They would just get comfortable with it and start trusting it a bit, and then they would see something else that would refute that. So there was a lot of, okay, it identifies patients who need attention, and it's useful in that regard, but not all of the alerts require action. So they were, struggling with that. They felt they needed some kind of data element to provide objective data and reduce the subjectivity of things, which, as you know, medicine is very subjective. So it kind of helped in that regard, but it was just a number if they didn't know how to interpret it and there was no clinical context. It was informative, but yet there was a lot of noise. So there was a signal to noise ratio that they struggled with. It's useful when it can confirm their clinical judgment, but there was a lot of discordance with the clinical data. There was a lot of times when the EWS was high and they couldn't figure out why, even looking at the clinical data. So there was a discordance with the EWS and the clinical data. In the paper are some really interesting quotes under this theme. So I recommend you look at that. Clinical actions, again, like I said, they didn't look at it at all initially. Once they were forced to, they started looking at it and integrating it. And some of them were really intrigued at this point. And they really tried, they remember when I said, if you click on a dot, it'll put vertical lines on so you can correspond the data. And they were clicking on dots to try to figure out what was making that EWS score in the danger zone. So they were trying to figure out the underlying algorithm and the clinical data. And it became like a puzzle for some of them. I think a couple of them just focused more on that than really just analyzing the case because they were so intent to figure it out and solve that puzzle. And the actions, again, were driven by their clinical gestalt. They relied on that. It was not commonly used. And they even said when they were asked what actions would you take on the EWS, they said, I don't know because I don't understand it enough yet. I don't trust it enough to make any clinical action judgments based upon that. They indicated if they trusted it, it might drive their actions, but the only thing they were willing to do would be to transfer someone in or out of the ICU, really was all they said. So the key findings are the knowledge level varies. Clinicians tended to think they knew how prediction modeling worked, and they really weren't explaining it right. So there's a lot of literature out there about the explainability of AI information and implementing AI applications with that explainability. So our findings kind of aligned with that. Operationalizing it, they weren't sure how to operationalize it. They weren't sure what to do with it. They didn't trust it fully, so they weren't sure what to do with it. But they were compelled, once forced to look at the EWS and consider it, and they did really want to solve the puzzle. And then the interface preferences came out both in multi-patient dashboard type views as well as individual patient views. So what do we need in order to optimize AI use in healthcare? Interface-wise, we need interactive visualizations and interactive interfaces that they can bring up underlying model explanations and help them understand it a little bit more. There's a lot of education, I think, we found that is needed to educate clinicians on aspects of predictive modeling and AI. And the education really needs to address the variable understanding and familiarity in general with how AI works. It needs to include education on early warning score generation and the predictive modeling process, description of model inputs and outputs, AI validation techniques, and then the limits of AI in prediction models. Clinical action related, we need education for clinicians on appropriate actions that should be taken on AI. They really need a clear understanding of should they be acting on this, and if so, what actions are appropriate. And it really needs to be conveyed, obviously, that AI generated information or augmented intelligence is not a substitute for their clinical expertise. And then, one of the things that came out is we really need qualified, trained people to develop the AI applications, and clinicians need to be involved in that process because they bring a vast amount of clinical expertise. But we need people who know what they're doing in developing these applications as well as integrating clinical concepts. So again, the question is, are we ready for real-time AI-based decision-making in clinical care? So I'll just open that up as a discussion. I think we have a ways to go. From our study, the clinicians were intrigued. They were willing to consider it, but there's a long way to go to gain their trust with it. So I'll open it for questions and just general discussion on that. Yep.
You mentioned noise, where the system was generating non-actionable alerts, or I assume stating the obvious. Did you look at sort of what percentage of the alerts that were generated actually had something that might contribute to a clinician's understanding?
We did not do the quantitative analysis of the alerts and the clinical data and which ones were reasonable and really were danger zones and weren't danger zones. So we didn't do that. The other aims, I don't think they're doing anything with that. I think aim 4, they might be moving into that. Aim 1 was to develop the temporal model. This was to get clinicians' perspectives for this aim. Aim 3 was they had a participatory design process. where they involved clinicians in designing interfaces. So that was really the focus there. Aim 4, they're kind of taking it all and bringing it all together. And they're creating some interfaces based upon what we found with this aim and the third aim. And they're doing some more real-time AI type components with that aim. They're going to do interviews and stuff with that. So I don't know whether they're going to do that there. We did not do that here. Just by listening to the clinicians as I interviewed them and listening to the pharmacist who took the clinical notes, there were some adjustments he had to make with the clinical notes that we got from Chicago to make more sense and align better with the EWS. And listening to him complain about how hard that process was, I don't know whether he had a sense of that or not. I don't have a sense of that though.
I'm just thinking of the famous stories of the drug-drug interactions that have something, you know, depending on where you are, but the override rate is always in the high 90s.
Yeah.
Because the sensitivity is typically set by the legal department, not by the clinicians.
Yeah.
And so it's warning of stuff that doctors always consider before they prescribe medication.
Yeah.
And it just becomes one more box you have to click through to get
Yeah.
your job done, but it doesn't add knowledge.
Yeah. Any other? Yeah.
Questions? And I am a clinician, like informatics interest, so thank you so much for doing this work. Was it just a one-time EWS score, or were you looking at like change over time? Because I think you could say the same for any, single number, single heart rate, single creatinine. It's hard to place it in context.
Yeah, let me go back to the screen here. They were given EWS over time here, and as they adjusted this, these scores adjusted. So they did do temporal reasoning with it. So they did have over time.
And then the other question was, how are you bringing it into collaboration with like EHR vendors? Because the EHR tends to be a fairly closed system, and I feel like that's one of the obstacles we have to innovation sometimes.
Yeah.
Is that, research can come up with really cool things, but then you kind of have to integrate it in one of the existing systems to get it into any sort of wide distribution.
Yeah.
So
that's the challenge of research and bridging, research findings to actual implementation of different things with EHR vendors and in general in clinical applications. I don't think there's any plan to do that with this study. And I'm not sure if they're planning on doing a follow-up study. University of Utah was involved in this. One of the PIs was from there. They would have the leverage to do that, where the university that I was from, Idaho State, don't really have the leverage to do that. So I don't know whether they're going to do that or not. I suspect not, but that's the challenge of all research. How do you take your findings and really make them impactful? And it's really challenging to do. Yeah, Terry.
So if you mentioned this, I apologize, but the EWS is looking at a diagnosis code. Is that true? I mean, something is doing a comparison to flag the EWS, and so it must be looking at metrics that are being collected and then comparing it against what, a diagnosis code? Is that how it works?
The actual prediction model underneath that creates the EWS looks at the clinical data, and it runs prediction modeling against a large data set of data to determine which variables accurately are going to predict deterioration. So, some of these.
So it's not looking at the diagnosis at all?
Not specifically, no. It's more the clinical data, what range they're in. There's some variables here that have a higher weight to predict deterioration, and she could probably explain this better than I can. But there's certain clinical data that you look at to determine if the patient is deteriorating. The diagnosis certainly, is a part of that as well. But,
It's
I don't, yeah,
very important to know what the diagnosis is, to know the impact of the variability of the metric.
right,
I feel like that's what you were describing, with like the clinician doesn't know what to do with this number. Like they don't know what to do with any of the numbers until you put it together into a diagnosis. Yeah, but the context is so important. So
Which is
you're
what-
getting from the score is like sort of some degree of sick or not sick, and then you still have to go figure out why.
Yeah, which is why is it being flagged? I mean,
it's,
tell me what the real issues are that are causing you to tell me that.
yeah. You know, if blood pressure was high and I'm not a clinician, so I can't really explain the whole intricacies of the clinical data, but there are certain variables that, and some of those variables contribute to deterioration more than other variables. So with the prediction model, it's really a list of variables and weights associated with each one. And you run that and you come up with a score. And the score, if it's less than 20, and the literature that I read from University of Chicago, who there's a person up there, she's got patents and everything on EWS. 20 was the threshold kind of that we were using here. But as you can see on the screen, I mean, this bottom number here is 37. We've got red numbers, you know, pretty high here. So if the threshold of 20 being, it's okay, and anything above that is reflected here, and the higher you go, you know, the higher risk of deterioration. So sometimes that wouldn't correspond with what they thought the variables should be allocating to that, like blood pressure. If, you know, there's no red here in the blood pressure, so they were like, well, why is this red? Blood pressure should be a key variable that you're looking at for deterioration. Platelets, of course, they do contribute to deterioration. So there's a lot of discordance that they saw in what the display was showing. I wasn't involved in AIM-1 where they actually created this temporal model, and they got data from University of Chicago and determined what variables should be fed into the model and what weights they should have.
Is this a logistic regression model?
I think it was. I think that they used regression on this. And that's where people were telling me at the end, well, that's not AI. And, you know, it's a prediction model. But
Do you mind repeating the questions? They're having a hard time hearing.
okay.
Thank you, Velma, for raising. I have two questions on contents of that. When you were interviewing the physicians, did they give a hint about if these algorithms are EHR or have a regulatory background, they're more likely to use this as compared to those who don't have them?
Did they have,
If they have regulatory backing, so for example, if a new algorithm came out and it went through an FDA clearance process, if the physicians give a hint of that, they will trust that algorithm more as compared to one that has not gone through a regulatory process?
okay, I will try to repeat that question. The question was about clinicians' background and whether they had a whole lot of background in,
No, so let's say the algorithm comes out, like the EWS algorithm comes out. Did they give a hint when you were interviewing them that if that algorithm had gone through the FDA clearance process, they were more likely to use the algorithm as compared to if it had not gone through the process?
okay, so you're asking about clinicians being concerned essentially about the validation process of the model. There were a couple clinicians that were very strong, had very strong opinions that they needed to see the entire protocol and the results of the validation of the model. And if they didn't see that and didn't have access to that, they were inclined to just not trust it at all. Some didn't even mention that, didn't have concern about that at all. There was two people that I interviewed. I'm trying to think. I think they were both, I think one was an MD and one was a nurse. The rapid response people, I don't think had a concern about that. There were a couple that were very concerned about, oh, well, I need to see how this was validated, and I need to see published literature that this was validated and how it was validated.
Also, another follow-up question. Did they mention how they would like to undergo the training, whether like model parts, label use of the algorithm, or seminars, like how would they like to be trained on how to use the algorithms? Just curious about if they know about that.
Yeah, the ones that did mention it, the question was, how did the physicians want to receive training on the prediction modeling and AI in general? A couple mentioned that, and indicated self-study type training that they could walk through on their own, videos and that kind of thing that they could walk through on their own. Obviously, they're super busy, so to go into a classroom and undergo formal training and stuff like that was not something that they were interested in. So we didn't specifically ask them about how they wanted to be educated. That was a kind of a finding that came out of our analysis, that they needed to be educated, because they were very confidently explaining how the model worked, but a lot of times what they were very confident about was not really how it worked in the end. Patrick.
So kind of along these lines, I mean, you mentioned at the outset that this isn't necessarily true AI, but you know, listening to the presentation, you can see where an AI overlay might be able to bridge some of the space between the model results and clinician concerns by, say, interpreting the signals or explaining the model or something like that. Based on your interaction, would something like that, would that be useful, or or do you think that would just create another layer of potentially distrust, or trust but verify, or I want to know how this AI layer works, and then I want to know how the predictive modeling layer works. So how do you think that would be received, something like that?
Yeah, the question was how would a true AI component be received? And that was the general emphasis of the question. Right now they have deterioration indexes in the EMR. They have sepsis indicators in the EMR. These are the same that I'm talking about here. So they've been using these for a long time. These have been embedded in EHRs for a long time. They're augmented intelligence. They're not true AI, but you could kind of consider them true AI because those components that Epic and Cerner have built in are reading data in the background. I don't know how much learning is involved with that, but they are sucking in data. Not sure how much the data set that they are, reading is being learned from that, which is a component of true AI. I think, the main overall factor is the time factor for clinicians. And they just don't have time to consider something they don't know a whole lot about. They don't know how it was generated. They rely on their clinical gestalt. Last year I was working on this, and one of the deans of the College of Health said that she had read some stuff about how these AI things built into EHRs have subliminal effects on clinicians, and that they're subliminally affecting their thinking. And she asked me what I thought about that. I said, I haven't looked at the evidence, but I can tell you the clinicians that I've studied, and I've been studying clinicians' thought processes way back for at least 10, 15, 20 years. They rely on their clinical gestalt. They aren't going to be impacted by subliminal messages from a score on the screen. I would love to look at the evidence that she was talking about, and I just never took time to do that. But they're open to it, which is positive, and they are really open to it. Things that cut down their time, all the AI applications that are out there that are helping them with their notes, they seem very on board with that. So they are on board with and open to using AI in clinical practice. But when it comes to adjusting their thinking, I think there's a bit of a roadblock there still. Is there any questions from Zoom? Okay. If you guys have questions from Zoom, just drop them in the chat, or I can't see Zoom here, so. Okay.
in general, it is like for time management, we love to use AI.
Mhm,
Cut
right,
stuff.
Right.
But when it comes to clinical decision making.
Right.
They will rely on data.
Yeah. Yeah.
That's all that. I think that the idea of like an explainer model on top is really interesting. I mean, logistic regression should be pretty explainable.
Sure.
Because we just have variables and weights. And I know there's some research around display of model outputs. And I forgive me because I did come in late and I don't know how much the display here was able to illustrate to the clinician sort of like in a way that's digestible at a glance, like how much the different elements of clinical data were being weighted in this logistic regression. Because like to me as like a critical care physician, like that would be helpful if I'm like, the score is high. Okay, why is the score high? And if it could like show me in a little bar graph or a little something, it's because of the heart rate and the blood pressure and the creatinine or whatever, great. Like then I can like, that's information I would be looking at anyway, and then I can digest it more quickly.
Yeah.
To me, that's useful.
Yeah.
But it's like also sort of the oracle problem. Like sometimes we all know the patient's getting sicker and there's not an intervenable thing to make them stop getting sicker, even if we all know that they're getting sicker. So we always talk about needing triage and like, you know, what level of care do we put them in? Do we move them to the ICU? But I feel like the problem of like just knowing that somebody's getting sicker doesn't always mean that I can stop it ahead of time. Is still like a super big problem with AI.
yeah, we did not tell them anything about, the algorithm and what variables were included in it and what weights were included in it. I explained the algorithm a bit, and really all I said to them was 20 is the threshold. You know, below 20, you're good, you're fine. Once you get above 20, you know, you start moving into
But that's
the,
like totally
Yeah.
not.
If you see
Patient is
these
sick. Okay, now I still have to look at everything.
in the context of the model with the weights and, you know, their contribution to the score.
Yeah, because I personally feel like not to do visualization.
Yeah.
EHR to make data.
Well, and
relevant
that's
to
where
the
I'm wondering if like a true AI that is learning can be that explainer layer, you know, where it's digesting the model, interacting with the clinician and then saying, oh, it's because the algorithm, this component of the algorithm has put this weight on this element. And that's why, you know, you're seeing
Yeah,
changes or something like that. But again, if there's a distrust, if you don't trust the, you know, the base technology and let's say you're worried about hallucinations or something like that, are you just adding another barrier or I mean, I'm sure it's, you know, it's going to be very dependent on just it's going to get down to the clinician level, just how comfortable they are with
Yeah.
the technology in general. But it seems like this is interesting because it does, to me, present a context where you can see, I'm an AI skeptic, but it does present kind of a context where you could see AI, like a generative AI being, having a value add.
yeah. And one of the things that you said that I'll go back to, which was available in this simulated EMR system, which I don't think is available in commercial systems. When they clicked on these dots, then a vertical line would show up on every single graph. So they could correspond the data, and they loved that. They love to be able to see, okay, at this point in time, HGB is here. So if I click, I don't have interactivity on here, but if they would click here, vertical lines would show up at the same point in time on all these graphs. So they could correlate data. So your comment about the interface and having features in the interface to enable them to correlate things, I think would be very helpful. That's not available in commercial EHRs, right? Depends on the system. Yeah, visualization is a real. Yeah, Terry.
But, you know, I really like the analysis that they did afterwards saying what would make it better. But another problem with this, I think, is you know, you're providing a warning, but in this context, it's static. And so you don't really know, did that warning, was it actionable? I mean, did something happen because you were able to follow the data over a longer period of time or something rather than just a static blip on the screen that said, well, this warned, and yet you don't have enough information to understand it, it seems. I do really like the click on it and have the lines everywhere. I think that's a great piece. I also like the suggestions about, you know, like a dashboard where you would see people who were flagged at a glance and then could go into those records. Rather than just looking at a single patient and seeing that. I mean, you'd want to see that too, but anyway, the fact is you have no way of verifying whether, well, yeah, that warning was valid.
Yeah.
Because especially in this isn't just some data that's put together and shows how the algorithm, what it reflects.
Yeah, and that's, a lot of them made comments. If you look in the paper, you'll see their quotes. A lot of them said, it's just a number to me right now.
Yeah,
I don't know what it's connected to. I don't know what to do with it. It's
Yeah.
just a number to me. But on the other hand, if what they were looking at in their mindset was what the situation was, and then they looked at the EWS and the EWS confirmed what they were already thinking, they loved it. You know, and there was such a discrepancy. The discordance part of the theme in the paper, really, it was a real predominant theme. It was almost as big as trust but verify, was, okay, there's a lot of discordance here.
Patients that were chronically ill, they're not changing very fast.
I would have to go back and look at that. I'm not sure if the discordance was in accordance with the chronically ill. I think if I remember correct, it was more associated with people with multiple chronic conditions. But I'm not sure, whether that was that or not. It was interesting to sit there and interview them and listen to them reason and stuff like that. Not being a clinician, I didn't pick up on a lot of the, you know, clinical aspects of things that some of the clinicians, as we were coding the transcripts, would bring into it. So
I think that's a very good point that, yeah, sick people are sick. And so when you have somebody who comes in, right, their med list is as long as your arm, right? And they've been that way for 12 years, right? They blow up all the algorithms because the algorithm goes, this person is not normal, oh no. And well, yeah, they've been that way for a decade, okay, goodbye, you know? It's like, you wanna know that delta, right? You know, are they suddenly getting worse? Also, if you can say, okay, 75%, you know, chance of needing ICU in the next 24 hours. Then you go, okay, you know, did I miss something? You know, when you've got sort of that kind of concrete prediction, it becomes more actionable. And then frankly, you also have the hospice patients, right? The ones who are coming in for palliative care. And yeah, you know, they're getting sicker and you know, they're going to die. And that was, you know, you're just making them comfortable. And you kind of don't want the system screaming at you going, this person is getting sicker. And you're like, yeah, that's the plan. You know, don't bother me. Let me focus, you know, let me do triage. Let me focus on the people I can save because all I'm doing is making this person comfortable. But the systems lack that kind of context. You know, that there's no way with these systems really to say, go away, don't bother me.
But with the introduction of AI and be able to put that
context
knowledge back
with
into
Yeah.
it.
Intrinsically, no. Because AI is a pattern engine and it only finds the patterns in the data you feed it. Right, so if you don't have any way of saying, you know, yes, this person is hospice and we're doing palliative care. If that isn't part of the way you structured the data you train the AI on, it'll have no idea. You are you feeding in the DNR status? Because you run the risk of the AI on its own will go, okay, this one's dying, we're not gonna worry about them anymore.
That should probably be a manual process.
Yeah,
Like-
that
like
could
you
go
have a
very
patient
wrong.
Comfort here in the hospital, you flip the monitor to comfort mode, all the numbers go purple and it doesn't alarm anymore. But it's a manual process, so nobody walks in. 72, no, the monitor's purple, it's okay.
One,
They're-
They had
they're-
that.
Huh.
How long have they had that? Oh, they definitely did not have that, so that was a long time ago.
one of the comments that one of the subjects made in regards to this conversation is there was a case here, the patient was gonna die no matter what. And she said, at least this number would give me an objective data element to take to the family who doesn't want to accept the fact that the patient is going to die and show them the data, here are the numbers, here's the normal range, here are the numbers. And so to take the subjectivity out of it and use the data, and not just the EWS, but the other data elements as well, as an objective measure that says, look, your kidney score is this, and you're dead when your kidney score reaches this. This was another measure that she thought might help with those kinds of cases where families just don't want to accept that their family's going to die. So it helps with the objective side of things. So, okay, I think we're at time. So thank you so much for coming. Thank you for everyone on Zoom.